So moving on, allow me to briefly introduce today's speaker. Charlie Alfero is a distinguished leader in rural healthcare development. Charlie currently serves as a part-time GME specialist with the University of Arizona's Area Health Education Centers program and is an independent consultant with the University of North Carolina's GME Technical Assistance Center and the SHEP Center. His work focuses on enhancing healthcare access and equity through systems change, program development, and policy support at various levels. Charlie has an impressive 46 years of experience in rural health policy and systems development. He served as the executive director and executive advisor to the New Mexico Primary Care Training Consortium, which he co-founded, and the Center for Health Innovation. His notable contributions also include establishing Hidalgo Medical Services, a comprehensive community health center in southwestern New Mexico, where he served as CEO for 17 years. Throughout his career, Charlie has directed numerous vital programs in New Mexico, including the New Mexico Office of Rural Health and Primary Care, New Mexico Health Resources, the State and National Health Service Corps programs, the National Center for Frontier Communities, and Forward NM. His extensive experience and dedication to improving rural health care make him a true pioneer in this field. With that said, Charlie, thank you very much for joining us today, and the floor is yours.
Hi, everyone. Nice to see you all today. I feel really honored to be able to give this presentation today, an organization that I have the utmost respect for, and providing an incredible resource for the state of New Mexico. And I'm glad to have been a part of that. So just a little bit of background. I've been in New Mexico now. This month will mark my 53rd year in the state. I came here as a child prodigy at the age of 8 months by myself. Well, just kidding. I've been here a long time. I came here to attend Western New Mexico University here in Silver City, where I still reside, or reside again. I have a degree in political science, a master's in psychology, and during the time I was working on my master's in psychology here in Silver City, I was offered a position in 1978 with the New Mexico Health Systems Agency, which was at the time a federally funded program, a national program, to provide health planning services throughout the country. It was sort of a precursor, created, I think, in 1974 to creating a national health plan for healthcare services for everyone. So I was the health planner in the southwestern corner of the state. And I had, during that time, the privilege of working with the Council of Governments and the Resource Conservation and Development group down here. And it was an amazing learning experience for me, working in an organization and with organizations that did community-based regionalized planning. We had incredible meetings on a quarterly basis in different very rural frontier places in southwestern New Mexico, and Alma and Glenwood and Animas and Playas and Columbus, where people from all of the 4 counties, elected officials and others, would gather to talk about needs in different priority areas, including healthcare. And we'd meet in the morning and somebody would host lunch for everybody. And then we'd report out to local government officials in the afternoon of what our priorities were. They would turn those into local priorities and legislation. And it was an incredible policy process from the bottom up. And it sort of gave me a perspective for the rest of my career on the importance of building whatever we do with the input of the people who are affected most by it. A year and a half later or so, I was offered a position running the 7 sub-area health systems agency groups from around the country, around the state rather, based in Albuquerque. And I took that, and during that time, I became the lead writer for the statewide primary care plan from the health systems agency. That was then approved by a statewide group of leaders that formed the board of the health systems agency, and that was then sent to the state Department of Health, Human Services Department, and others for consideration in their policy work. So it was a great policy process. Next slide. So in 1982, I was asked to become the first employee of the State Office of Rural Health, um, as a result of a change in policy during the Reagan administration, whereas before 1982, federal employees of the U.S. Public Health Service and the DHHS, Department of Health and Human Services in Washington, were placed in states to help develop primary care programs and develop National Health Service Corps positions in each state. And as part of his program to reduce the federal government size and give states more responsibilities, they then contracted that work to states. And New Mexico was actually the first state to have a contract with the National Health Service Corps to develop National Health Service Corps programs around the state. Fortunately, I was lucky enough to work with the feds who were in the state during that time for quite a while during a transition period. And it was quite a process of developing primary care. I'll get into that a little bit more as we go through this. Later on, 1986, as Reagan ended the National Health Service Corps program pretty much completely, we went from 37 or so placements a year of National Health Service Corps obligees and obligors and federal employees that were working for the Commission Corps and the National Health Service Corps through the civil service. We went from about 37 a year to 3. I left the state and went to run New Mexico Health Resources for a while before becoming Director of Policy and Finance for the Hospital Association. In 1992, I got a call from the Secretary of Health and the governor at the time, Governor King, to ask me to come back to the Department of Health to work out of the Secretary's office on rural healthcare issues and development in the state. With the end of the King administration, I moved, after doing some consulting in Nebraska and Louisiana, I moved to UNM, became their first Director of Rural Outreach in what is now the Office of Community Health. And when I did that, I wrote in my contract that we would start Hidalgo Medical Services. And I essentially became, at that time, the first hero at the UNM Office of Community Health, as I was a UNM employee while also directing HMS for a while, and HMS would reimburse UNM for my salary. Next slide. So from 2001 for the next 12 years or so 17 years in total, I became the CEO of HMS. During that time, we grew from 1 location in Lordsburg to 12 locations in the 2 southwesternmost counties in the state. We added dental services early on. We added mental health services early on. And a few years into that growth, we added our family health services, community health worker model at HMS. And we did that in a collaboration with UNM under a REACH grant, Racial and Ethnic Approaches to Community Health. And prior to that, we had done a model which got published on how to finance community health worker services via Medicaid, MCOs, and that became sort of the basis for our community health work moving into the future. During and after my stay at HMS, I worked on developing a number of other sort of nonprofit organization working on various aspects of healthcare you see listed here. And then a few years ago, I stopped working, or last year stopped working for the Consortium and Center for Health Innovation, and started doing consulting work last summer for University of North Carolina, the Shep Center. Shortly thereafter, about a year ago right now, I got called by the AHEC program in Arizona. They had just passed some legislation to do a graduate medical education planning and development program modeled pretty much after the New Mexico model and the health and the consortium and Medicaid funding of planning and development. However, it has a decidedly Arizona looked to it, and it was determined that the entire program be placed in the AHEC at University of Arizona in Tucson, and also part of the Center for Rural Health. So that's what I do now. I work half-time, University of Arizona, and I work for University of North Carolina as a consultant on graduate medical education programs in both states. And that's going to be the short version of my work history. If anybody has any questions, let me know as we go on to the next section. In that next section, I wanted to just take some time over the next few slides to really acknowledge people that I think were leaders in primary care development in the state over the years. Those people, at least, there are lots of others, but these are folks with whom I had a relationship over the last 46 years, some early on, who are no longer involved directly in the programming. But I wanted to point out that there's John Glass and Harvey Lisht, who worked in northern New Mexico and Santa Fe, and then north central New Mexico, designing the first sort of primary care plan for the state, where they looked at concentric circles of access to healthcare and how communities could fit into levels of care based on their distance from hospitals and other factors. And it was really, I thought, still a great model for looking at how to design health systems around primary care. John later became a major planner and developer of the Presbyterian Medical Services program after working on planning development in north central New Mexico. Barrick Wolf was the first Fed, I talked about earlier, Feds being placed in the state to work on National Health Service Corps. Barrick Wolf, who just this year retired, or will this year retire from supporting the Senate Public Affairs Committee during a legislative session. He left the Department of Health after transitioning from federal employment a few years ago, and became the lead staff person for the Senate Public Affairs Committee in the legislature. Just a storehouse of history and information and policy perspectives. And I was really lucky to have Barrick and his successor and federal employee successor, Herman Martinez, who was originally from Las Vegas, New Mexico, but also a federal commission corps officer I worked with early on in primary care development. Just wonderful people. Carol Miller, who's still around in Ojosarco, who worked in Tierra Maria for many years at La Clinica up there, and is still very active in frontier issues in New Mexico and nationally. Martichel Chacon, who was the CEO of Centro Capacitaciones de Salud, which is now Centro in Española, was also a member of the New Mexico Health Systems Agency when I worked there early on. Again, a sort of a visionary, and laid the groundwork for the future of what is now El Centro many, many years ago. I think initially with just migrant health money. Lots of other people early on that I worked with that provided a lot of support for concepts and development around primary care and rural hospital access. And I've listed some of them there, and I don't mean to exclude anybody. They're just who occurred to me on probably a Saturday morning when I was writing this slide. But there are lots of others. Next slide, please. And here's some other ones. I think one of the interesting policy developments early on in my career, and I came around towards the end of this, like I said, Ronald Reagan essentially nixed this during his administration in the early 80s. But there were lots of doctors who I worked with early on primary care development around the state, were what we used to call, I should say, red, white, and blue, not red, white, and blue docs. They were commissioned corps officers. They wore uniforms on Wednesdays to their clinics. They're one of the 7 commissioned corps officers are one of the 7 uniformed services in the federal government, along with the Army, Navy, Air Force, et cetera. and they're federal employees who were career officers who were stationed here in New Mexico to do work. Alan Firestone was in Bernalillo, and when I went to work in 1982 for the state, I did my first month working at the clinic there, learning how to run a National Health Service Corps site where we did all the billing and finances on graph paper because we had no computers back in those days and everything was done by hand and in pencil. So you really learned how to do things from scratch when you learn how to work in a clinic like that. And of course, Art Kaufman also spent time with the Indian Health Service. Most folks know Art Kaufman, who's been an incredible leader for primary care development here and internationally as well, and a mentor for a very, very long time. At the same time, this public National Service Corps program stuff was going on. There were private docs still working in rural areas in the state, and they were often solo docs running hospitals, and they were post-World War II rural providers. And I have a little bit of data on that in the next few slides. But I got to work with Dr. Baxter in Lordsburg, who single-handedly ran the hospital for a while until he could no longer do it. He was replaced by another solo physician in Lordsburg running a hospital, Dr. Charlie Young, who unfortunately got into a motorcycle accident and tried to run the hospital from a wheelchair with his wife's assistance, but couldn't do it. So that hospital closed for the last time 6 months after we opened it in 1980 or 81. And for the last time closes the hospital. Dr. Foster, who was up in, and later Dr. Heinekamp, who up in Reserve, New Mexico. Incredible, just crazy stories that I can tell about this. But Dr. Foster was essentially an acupuncturist and a proctologist who was providing primary care and running a small hospital in Reserve, New Mexico, but he was also blind, legally blind. And his wife was a nurse, and she went into the hospital and the patient rooms with him and saw the patients together with him. And oftentimes he was paid in those days with wood and chickens for providing healthcare services to people. So that goes really pretty far back there. And I started the people who, on the last couple of slides, were all people who were, I would consider, pioneers in rural health and primary care development in New Mexico, including myself, who were from within an hour of Manhattan, which I think is a real interesting sort of issue. Next slide. And in the last more recent times, long list of people who I would consider mentors and supporters of the work that we've been doing. And I won't go through everyone. You can see, you don't know most of these people, but some of the key HMS board members that allowed us to do expansion in the early years, and who was very encouraging and risk-taking. And for instance, agreed to open a school-based health center in Baird without any public money, just using the money that we had generated from seeing patients in public funds in Lordsburg. And that was an unusual thing for Hidalgo County to provide resources to support primary care delivery in Grand County, where Silver City is usually the trickle down went the other way. We later got federal grants and state funds to provide healthcare in Grand County as well. But that first venture into Grand County was done solely with HMS resources generated in Lordsburg. And lots of publicly elected officials who have been key over the last 25 years or more in financing primary care developments. There are a lot of people not listed on here. And I'll get to some of that in a little bit. And special thanks to Dan Dirksen, who I work with at UNM on the first three 1+2 programs in the state in Santa Fe, Las Cruces, and Roswell, who is now the director of the Center for Rural Health and the vice president of the Health Sciences in Arizona, who asked me to come join him over there to work on GME last year. Next slide. So some things that we haven't done in New Mexico is I've been around a long time, but I wasn't around for the first doctor ever who was in Egypt 45 or 6,500 years ago. And I wasn't around for Matteo Salvatico, who was a doctor who worked in Rome for a long time, but helped start a medical school in Salerno, Italy. And in those days, before chemical medicine, he had a model of looking at how to look at health, where he classified all diseases as either wet, dry, or hot or cold, and all treatments, herbal and other treatments for those diseases as wet, dry, hot, or cold. And so if you had a hot disease, you got a cold treatment. And if you had a wet disease, you got a dry treatment. And there's the Gardens of Minerva in Salerno, Italy, which I've been to 3 or 4 times, which I just think is a fascinating thing to go. So if you're ever in Italy and want to see the origins of Italian medicine, I would suggest going to the Gardens of Minerva. They're pretty cool. They wrote all these plants that grow in this part of the garden you see here come out of a spring that generates in the mountain, which this garden is attached to. So it's a special place. Anyway, enough of that. 45 seconds of ancient history. Next slide. So it's a little ancient history in New Mexico, not quite as ancient. There's a book that was published 1984 that I got online when I was looking at how to prepare for this talk. It's called Doctors of Medicine in New Mexico, written by a guy named Jake Spidell, who I didn't know. But as you can see, the trends in access to healthcare in what was at first the territory of New Mexico and then the state of New Mexico. We had 99 doctors in the whole state in 1886. By the time we reached statehood, and then World War II, we had 447 docs. And before UNM started a medical school in 64, we had 715 physicians in the state. And that translated into a population to physician ratio, 1 doc for every 1,300 people. Shortly, 5 or 9 years after UNM, that ratio went down. And then, as you can see, we grew significantly over the next 12 years as a state population, and our ratio of physicians to population went back down again. And our physician population grew dramatically. And by 2021, we were down to 1 for 251. Although I question this data that I got online, and if people have better data, please don't hold me to this. It was very confusing trying to parse through what UNM had done in terms of workforce studies and look at licensure and things like that. So don't hold me to these numbers, but as you can see, the numbers have improved over time. Next slide. Another thing I found really interesting looking through the data in this book I just showed you is even as late as 1983, we were defining primary care as general practitioners. And in 83, there was a specialty for family medicine. But in terms of this book, at least, and counting primary care docs, they included family docs as specialists, not primary care providers. There was a differentiation between people who were boarded and people who weren't. And you can see during that time, our number of GPs dropped and the number of specialists we had exceeded the national percentage of specialists. And if that doesn't make sense, raise your hand or jump in. I can't see you all, so I don't know if anybody's raising their hand or anything. So anyway, I just thought that was sort of interesting history. And it was a fact that many of the docs who were in the state came from Missouri and the DO osteopathic training programs in Missouri. Many of them also attended the 1-year internship program at University Heights Hospital in Albuquerque on University Boulevard, which later became Carrie Tingley Hospital. And they got 1-year internships. And in those days, you could become a physician licensed in the state to practice with 1-year postgraduate internship. I actually sat in several years later, not all that many years later, in a legislative session in a debate between the legislature and the Board of Licensure and the New Mexico Medical Association, where they wanted to change that to 2 years and then later board eligibility before you could become licensure. And that's why there is a special licensure category for residents now, because we no longer have the ability to license people to practice generally after 1 year of training. So all those docs I mentioned earlier that were doing one year of training and running hospitals in New Mexico, many of them came from the osteopathic medical schools and did a 1-year internship in Albuquerque. And I can tell you about more of those places if you're interested. Some of them were horror stories, as well as the friendly old family doc stories. Next slide. So I don't want to spend a lot of time on the need for primary care. Hopefully, if you're on this call, you understand that we are incredibly short nationally in terms of access to primary care and primary care physicians. And I'm focusing a lot on physicians in this talk because it's the Primary Care Training Consortium, and that's who we train, or the consortium trains as primary care physicians. I'll talk a little bit about policy issues in the next 15 to 20 minutes that I think have affected access to healthcare negatively in terms of primary care physician supply, and also some hope for the future about what you're doing with the consortium and how what I consider to be the only way to remedy continued access to OB and other hospital inpatient and more efficient, effective, and rational healthcare by training physicians in the places we need them. So I'm sure you all have your prologues to your grant applications where you describe the horrors of the lack of access to primary care effectively. And so I won't spend a lot of time on that. So next slide. So there have been historical efforts to eliminate or alleviate shortages in primary care in the state. UNM Medical School was created with the mission of eliminating or resolving or addressing health professional shortages throughout the state. And we've always had a reliance, and will always have a reliance on other states for the supply of physicians necessary to address shortages in primary care. But as you know, UNM has developed over time as a tertiary hospital focused, tertiary services hospital focus. Like most other urban hospitals in the country, the ratio of primary care physicians being trained to subspecialists is not sufficient to address primary care supply. And in fairness, there is no way that any one institution or two or three or four should be held accountable for addressing public needs that are as serious as access to rural health care. And I feel, there's a lot of recognition UNM gets for its rural programs, and I appreciate that very much. And they've done a great job of outreach and services, but I do believe that there are, limitations. Historically, as I mentioned, Heights General provided support. It was Ted Kennedy in 73 or so that had a plan for national health insurance when what's his name was president it jumped out of my head right now. And it was negotiated that the country would not follow Ted Kennedy's plan for national health coverage, and that they would use health maintenance organizations as the way to resolve that based on the models in California. However, a lot of what Ted Kennedy had in his plan still exists today, like area health education centers, which are designed to work in rural and underserved populations to generate interest in health careers as part of a pipeline model. Then the National Health Service Corps would be there to give people scholarships and get them to enter health careers. And then there would need to be a place for patients to go and National Health Service Corps providers and others to work. And that became CHCs. They were called something else. As well, earlier on, there were urban health initiatives, rural health initiatives that later became totally is it time to go, Jay? Anyway, from a state level perspective, I believe in 1976, Mora Valley Health Services became the first clinic in New Mexico to receive operational funds from our state legislature. So we had one clinic in the state receiving funds. And again, in the 70s and early 80s, and even in the 90s, there were some single physician run hospitals in the state that were not state funded. I tend to come from a very public perspective on this because if we didn't have a lot of the programs that I'm going to talk about here in the next few minutes, I don't believe we would have much access to healthcare at all in rural New Mexico or America. Next slide. I'll try to go through these. The late 70s, again, we've had migrant, urban, rural health initiative centers. They helped establish clinics in Espanola, Hatch, south of Hatch, Dexter Hagerman, I think Portales, South Valley of Albuquerque, Cuba, other places. Lots of freestanding National Health Service Corps sites. And what that means is basically the National Service Corps would come in, set up a public or private nonprofit organization, teach them how to run a clinic, and then send them a doctor. And those doctors would provide services. Later on, nurse practitioners and PAs were added to the mix when the federal government could place federal employees in states that did not require that provider to be licensed in those states. So there were nurse practitioners and PAs practicing in states as federal employees in states that did not acknowledge them under state licensure. And I think that was a very strong development. Later, most of those went away under Ronald Reagan and subsequent, and those federal employees were replaced often by loan repayment recipients through the National Health Service Corps, and then later on, state loan repayment. In 1979, there was the first governor's conference on access to healthcare and primary care in Albuquerque. There were 600 people there from around the state. I was one of the staff people through the Health Systems Agency at that conference. It was decided that there would be a commission appointed to work on access to rural healthcare. That commission lobbied the legislature to fund its top priority, which was to recruit and retain health professionals in New Mexico. And their first act was to create state funding, I think in this 1980 legislature, which created language in the legislation for the Department of Health to fund New Mexico Health Resources. And I actually was their project officer when I got that job through the National Health Service Corps at that time. Next slide. So a lot of things happened really in rapid succession in the 80s and 90s. Some of them more interesting than others, but one of the things that Ronald Reagan did was start charging these freestanding National Health Service Corps sites for the doctors. No free ride with the federal government under Ronald Reagan. And so they would have to pay a percentage of their gross income to the federal government for operating. And if you know any business math at all, you can't take that kind of money off of your gross income. So we actually went to Congress and changed the federal law requiring that paid back so that clinics were paying back for federally employed providers on their profit. So they were giving 10 or 15% of their profit versus 15% of their total income. And that would include then state financing, which was also kind of weird. We'd give the clinics a little bit of money and they'd have to pay back the federal government for those funds. It was around that time that we started, next slide. Around that time, we started financing clinics through state Rural Primary Health Care Act. We added to the recruitment and retention responsibilities of the Department of Health by saying they would start funding clinics in underserved areas. And we had, at that time, we had $100,000 and we funded 15 clinics around the state at $6,000 a piece. And they bought defibrillators and some supplies. And then rapidly, we started increasing the amount of money and the number of sites in New Mexico. And one of the insights we had was to require the clinics that we were giving state funding to have the same sort of requirements for operational funding as the community health center program. So we didn't require a different model for eligibility for state funds. We basically took what the feds did. And for new places that weren't clinics yet, we use the same rules for board membership. We use the same rules for policies and procedures. We use the same rules for sliding fee scale as federal clinics. So when the federal government vastly expanded funding for community health centers, there were lots of places in New Mexico that were eligible for the federal grants as well. And at one point, we had more federal funding per capita for community health center programs than any state in the country. I'm not sure that that's same. That holds or if that's true today, but it was true at one point, and I owe that to making all of us in the Primary Care Association members and others making that decision to make state-funded clinics look like federally funded clinics. In the late 80s, I think a sort of a landmark event was creating the Medicaid and the Medicare program that's called federally qualified health centers, so that all community health centers that were grant funded in programs that look like them could get a differential payment other than, that was better than a private sector fee-for-service model, and start guaranteeing the cost of providing healthcare under conditions that were accountable because they were community health center programs. I won't read all of this. So at that time, we had some rapid growth. Next slide. In the early 90s, there was an Office of Rural Health established in the Department of Health Secretary office that I worked with for a while. In a big landmark federal state legislation, there was Senate Joint Memorial 19, which instructed DOH and UNM to develop a primary care proposal to improve access to care that Dr. Chris Urbina from UNM and myself co-chaired. We had, and I think it was, 30 or so pieces of legislation that was introduced in 1994 that all passed through the legislature. Every single piece of legislation we had as part of that memorial study was funded, included funding the 1+2 residency programs in the 3 places outside of Albuquerque, expanding RFCA funds that created a primary care capital outlay funding so that clinics could improve or build new clinics. There was a pre-PA program established at UNM. There was a rural family nurse practitioner program was established for a while that didn't last very long, but was there. Loan repayment expansion, and many, many others that were created to improve access to primary. There's really a landmark bit of expansion. And then we had the 1+2 programs expand and develop at that time for graduate medical education, all owned and operated by UNM initially, and then 2 of the 3 became independent later on. I mean, one became independent, one of them closed, and the other one is still a UNM program in Santa Fe. It was at that time we also created Hidalgo Medical Services, which I listed because Hidalgo County was the last county in New Mexico without any access to healthcare. And in a partnership with UNM and the community, we were able to develop HMS in Lordsburg, New Mexico. And another sort of reason to mention HMS specifically is it became the next residency program to open in the state after the 3 1+2s here in Silver City. Next slide. There were some downsides, I think, to some of the really positive policy work that went on during the 80s, 90s, and 2000s that I think have created a dilemma for access to healthcare, sort of unintended consequences. And when things move from totally cost-based reimbursement to PPS type models, there became an incentive. PPS stands for Prospective Payment System, which gives you a flat rate per patient visit, regardless of what you do with the patient, whether it's a 99212 or 99215, you get the same amount of money. It created incentives to do volumes in healthcare as opposed to community integrated healthcare. Some organizations have done an excellent job of not sort of succumbing to that and maintain a hospital presence and deliver babies and still are fully integrated into the community health centers. But many places have opted out of that, and there are other reasons besides PPS for that. But I believe sort of this effort to fund clinics in a much better way to ensure access to care for underserved populations in some ways had an unlikely impact on hospital access, including access to OB services in the country, which, as you know, is a very difficult place right now, access to OB in rural areas and other places. And again, this is one person's opinion of the last decades of development. Other positive things have been community health worker modeling that have developed over time. School-based health centers are everywhere now, which I think is important. Next slide. The ability to grow graduate medical education programs has grown dramatically since the ACA. And I think even though the funds for teaching health center graduate medical education programs have been limited, and they only started funding planning and development recently, that this idea that training could happen outside of the 4 walls of a tertiary hospital was sort of burst open with the teaching health center model. And even though a lot of places don't actually have the teaching health center, the idea of hospitals working with independent community-based organizations to do graduate medical education sort of really has grown over time. And a lot of the programs we tried to do 10, 12 years ago through the consortium were opposed politically at our state legislature, and even I think at the federal level by some primary care and hospital organizations. And that newness now has worn away, and people are realizing, I think, more and more that they have to solve their own problems and access to healthcare, that tertiary hospitals won't solve everybody's problems. They may solve a lot of problems, but they won't solve everybody's problems. And in Arizona, a year ago this time, there were 5 community-based organizations looking at developing GME. And a year later now, there are 14 looking at developing GME. So, and that sort of growth is happening nationally as I see it. And so graduate medical education and the ACA, I think, are closely connected. The planning and development funding was approved from a language perspective in the ACA, but not approved for funding initially. It was only approved for that about 4 or 5 years ago. Next slide. So what does it all mean? Right now in New Mexico, I looked on the Primary Care Association website, about 1.55 million patient visits in various programs delivered in 2003 compared to the 15 clinics we had seeing maybe 1,000 patients or 2,000 patients a year back in 1982 or so. 80% of all FQHCs are located in rural areas. And when I think about the incentives we had for developing rural programs in New Mexico, I like to think that loan repayment, the RIFCA, Rural Primary Healthcare Act programs, and recruitment programs, 1+2 programs, that all had a big impact on that improvement to access to care. That our work with the Primary Care Training Consortium was critical, timely, and ahead of the curve nationally. And I think we're well placed to increase the quality and quantity of primary care training in the state and other places. And we are a leader in that. I still get asked to talk about nationally almost every other month or so about how to work on establishing and creating a consortium from scratch. And it's very positive, wonderful. Working on a consortium in Arizona, or multiple consortia in Arizona right now, working on a TA program in Missouri. There's one they're thinking about doing one in South Carolina. And also other people are looking at the New Mexico model and how we changed Medicaid financing of graduate medical education a few years ago in the state. That was all done through the consortium. So there's a lot that everybody here should be thankful and grateful for and appreciative to be part of. I know that I am very appreciative to have been part of that. There are a lot of things that we need to do to improve access to timely care. But I think this GME program is one of the keys. That graduate medical education is a key. Next. So the laundry's never done. And if you want to, there's always stuff we need to do. We need to improve GME financing and Medicaid. We need to figure out how to solve psychiatric graduate medical education payment system, which is totally insane from a national perspective. It's the most crazy thing that I've ever had to think about and work about in my 50 years of health careers work. We need to figure out how to take all of the new medical students that are coming out of new medical programs around the country and gear them to primary care access in better and ways and in more numbers. And we need to provide better incentives for primary care training in urban areas as well as rural, in my mind. And it's really been more fun than I can imagine, as well as incredibly challenging. And it's even more fun if you're working in a people-first environment. And I hope that our future directions in healthcare in the United States will focus on people rather than profits. And I don't believe in holding companies running our healthcare system in the country. And I hope we move away from those models as we move forward. That's it. That's all I got. 5 minutes for questions.
All right. Does anyone have any questions?
Well, next slide. You all need to get a hold of me if you have any questions about anything I said or what I'm doing. Please feel free to contact me anytime, now that I'm semi-retired.
I go to
type your question.
Okay, we're unmuted in here.
Oh, can you hear us? We have a question.
Let me answer the one on the chat real quickly. How do you see the state policymakers' willingness to increase primary care preventive resources in the coming years? New Mexico, I think, is a leader in that. I think there are a lot of people who have done a great job of talking the primary care or telling the primary care story in the state. They have always been supportive. I think they're always looking for new and improved ideas. I think we need to work with our state policy administrative leaders to think about access to healthcare in different ways, like not just counting the number of providers in a community, but looking at the mix of providers and figuring out whether that mix can sustain a full range of services that community can support, including hospital care, and make sure that how we finance provides and serve as incentives to create that mix of providers. It's a lot easier to hire providers who cost half as much as other providers. But if you do enough of that, there may not be a sufficient range or scope of services in the community to provide everything that community needs in terms of access to healthcare. And I think we need to do that, with primary care obviously being the base. Other?
Can you hear us?
Yes, I can. And thank you for being here.
You mentioned that they were expanding GME in Arizona. I was just wondering, do you have a sense of whether it's in what specialties they're expanding GME?
Yes, the specialties that are allowed under the new legislation include general surgery and OBGYN, et cetera. However, if you think about, if you think that it takes a provider to train a provider, there's not a lot of OBGYNs in rural Arizona, and there's not a lot of general surgeons available to establish a training program. So the vast majority of programs are in family medicine. There's 3 in psychiatry. There's 1 in internal medicine in Payson, which is only an hour from Phoenix. So the vast majority of demand for training and programs is in family medicine. And I'm finding that in the work I do nationally as well. I believe that rural hospitals administrators, as well as community health center folks that are involved in inpatient as well as outpatient care, understand that a family medicine provider provides a wide range of services, including potentially OB and C-section capacity or capability to meet needs of rural areas. And that generalist, expanded specialist generalist model, I think, is the future of access to rural healthcare in a lot of places.
Thank you.
Did I answer your question?
Yeah, it did.
Okay.
All right, so we're right up against the hours. So Charlie, do you have any closing thoughts you want to share with everyone?
Yeah, this is really quite an honor. And Nora, thank you, and Esther and everyone for all the work you did in Espanol to make that program possible this year. It really touches my heart to see what you did there. And you should be very proud of yourselves and your first class and the folks supporting them. Thank you all for being there. You're breaking ground and proving very important points.
Awesome. Well, thank you, Charlie, very much for that great presentation. Thank you all very much for joining us today, and have a great rest of your day.